today is a great pleasure for us to have the privilege of inviting Professor David Newey, who is the British Heart Foundation Duke of Edinburgh Chair of Cardiology at the University of Edinburgh and Director of the Edinburgh Clinical Research and Imaging Facilities. He's a consultant interventional cardiologist at the Royal Infirmary of Edinburgh, and he has a major interest in experimental medicine, imaging, and clinical trials of cardiovascular disease, including coronary disease, aortic stenosis, and heart failure. He holds a British Heart Foundation program grant and a Wellcome Trust Senior Investigator Award to explore advanced imaging in coronary heart disease. I think he's most well known for the seminal work that he has led as chief investigator for the SCOT Heart and the SCOT Heart trials. For those of us that started early with the development of cardiac CT, really have seen these trials as the most impactful in the adoption of CT as what is now the leading technology for evaluating patients with symptoms at an early stage. I just want to remind to the faculty, you will receive a message today that our scheduled afternoon faculty meeting will be rescheduled due to the holidays. And I hope that you enjoy this presentation. Dr. Newey, thank you very much for being with us today.
Yes, and thank you very much for the kind invitation. And it's lovely to be with you, albeit virtually. And I hope you're not having too much of a disruptive day. So what I'm going to talk to you about is obviously non-invasive imaging of coronary disease. I'm going to split this into sort of three thematic areas. I'm going to talk a little bit about the SCOT Heart trial, and then some of the reactions to it, then how we went on to look at how to develop CT, and then perhaps ultimately some novel treatments that are coming around the corner. These are my conflicts of interest, and the ones in red are perhaps relevant to today. So this is the three-part summary of the talk, and hopefully towards the end we'll get a little bit more away from CT and just discuss some interesting other things that may be coming over the horizon. So first of all, I was lucky enough to lead the SCOT Heart trial, and at the time we set this up, which was around 15 years ago now, what we wanted to know is what was the additional value of CT angiography. So this was adding it on top of what we already did in our cardiology clinics when we referred patients with stable chest pain. And obviously the question on the top of the list is, does this person have angina due to obstructive coronary disease? And therefore we're using this as a diagnostic test. And therefore the primary endpoint of the trial was actually the diagnosis of angina due to coronary disease. Of course, if you change or modify the diagnosis, that will inevitably change the investigations, the treatment, and maybe even their outcome. And we pre-specified that this technology might indeed improve 5-year coronary heart disease death or non-fatal myocardial infarction. Although that's obviously a long-term aim because it takes many years. And the primary aim of the study was as a diagnostic tool. So this is the sort of schematic for the Scottish sort of healthcare system, or UK healthcare system, really. Primary care physician refers a patient up to the cardiology clinic where you have a consultation, history examination, 12-lead ECG. Very often, usual practice in the UK is to do an ECG there and then because it's simple, available, and right next door. So we often do that in the clinic, but then come to an ultimate diagnosis plan, investigations, and treatment. Now, obviously, that investigations might lead to perhaps a perfusion imaging, further testing, or indeed direct angiography. And it's only as the patient was really leaving the clinic did we actually approach them to take part in the SCOT Heart trial. And they were randomized 1-to-1 to either standard of care alone or standard of care with CT on top of it. And then we wrote to the clinicians 6 weeks afterwards to tell them the result of the CT angiogram, but also as a control prompt, we also gave them a cardiovascular risk score. So in Scotland, we call that the assigned score, but it's the same as the Framingham risk score, really. It does have more details, and it is actually suitable and calibrated for the Scottish population, so it's more relevant to the Scottish population. But we gave them another prompt this patient has a risk of X of having a heart attack over the next 10 years. Do you want to do anything different? And then the clinician had to document if they changed the diagnosis, if they changed the investigation or treatment plan. And then we followed them up. And we recruited people in about 12 centres across Scotland. 3 centres were imaging centres, so some patients did have to travel quite considerable distances to get scans. But nevertheless, we did it across the central belt of Scotland where most people live. We then followed them up using electronic health record systems and data capture over the succeeding 5 years, and we can get back onto that a bit later. So what did we find in the trial? Well, in around the 4,000, just over 4,000 patients, the CT scan did change the diagnosis in terms of the diagnosis of coronary disease. Of course, it's probably the best test of non-invasive assessing that. And the certainty doubled or even trebled in the certainty of whether someone did or did not have coronary disease. And the frequency of detecting coronary disease was a little bit higher, so it increased that diagnosis. When it came to the primary endpoint of the certainty of whether someone had or did not have angina due to coronary disease, that doubled. And interestingly, the frequency of angina due to coronary disease actually fell a little bit in terms of frequency. It was 36% in the standard of care arm and 30% in the CT arm. And I think what that tells us is that we tend to overtreat people. We'd rather treat too many than too few because we're all a bit afraid of missing something and the patient then having a heart attack. But the CT scan clearly gave us the confidence to say, actually, although it sounds like angina, this is not angina due to coronary disease. So did that make a difference to the patients and how they were managed and treated? Well, it did. Sort of in line with what I've just told you. Preventative therapies were stopped in some people, but many more were started. And that's sort of consistent with the fact that the frequency of the diagnosis of coronary disease went up in the CT arm. Whereas the reverse was true with anti-anginal therapy. Yes, some were started, but many more were cancelled because it was a slightly lower frequency. So really the treatment changes did mirror what the CT scan findings and how they affected the judgment of the clinician. And here's just an example of aspirin statin therapies, and you can see that across the 5 years of follow-up, patients did indeed more likely to take antiplatelet and statin therapy. And that obviously is part of the benefit of the CT. It detects coronary disease and initiates not only lifestyle interventions, but also, as you can see here, preventative therapies. What about coronary revascularization? CT scanning has always been criticized a little bit for encouraging revascularization. And indeed, as you can see in the Scott Heart trial, the CT arm in blue did indeed in the first year have an excess of 20% more coronary revascularization. So it did prompt it. And I don't think we should apologize for that. If the CT scan diagnoses the condition better, then clearly it's going to find obstructive disease that we've missed and then get the appropriate treatment. So that's not necessarily a bad thing. But what is very interesting is what happened after the first year when all the revascularizations triggered by the CT scan had been completed. You can see that the frequency of revascularization after the first year was lower with CT because, of course, you'd found the people and you treated them and they didn't then re-present or re-attend. Moreover, perhaps the initiation of preventative therapies prevented the occurrence of downstream myocardial infarction so that, again, less revascularization was performed. And then when it comes to the clinical outcome, the one that we were most interested in after 5 years, we did indeed see a reduction in the rate of fatal and non-fatal myocardial infarction, as you can see here. I always like to point out the Kaplan-Meier curves in the first 2 or 3 months there. You can see they overlap quite a lot. And that to me gives me reassurance because the CT scan at the end of the day is an investigation. It's not a treatment as such, but it guides how we treat people. And what we found was that on average, it took about 3 or 4 months before the CT scan was performed, reported, fed back to the clinician, fed back to the primary care physician who then changed the treatment. And so that treatment delay, you can see that the event rates are identical. It's only once the treatment changes do the curves separate. So giving it some really quite robust internal consistency, I think. So overall, the summary of the Scott Heart trial was that it did change the diagnosis in terms of certainty and frequency of coronary disease and angina due to coronary disease in 1 in 4. That did change and alter investigations, cancellations of perfusion scans, cancellations of invasive cath, but also the reciprocal. And treatments were changed in 1 in 4. And overall, that led to arguably nearly a halving of myocardial infarction. So it did generate some fair interest, and I suppose, as always, having done many trials, actually, there have been neutral findings. It was quite nice to finally have a trial that was actually showed a significant benefit. But of course, this did generate a lot of interest, particularly in North America. As you can see here, it was lit up quite a lot, quite contentious issue, I think more for the US. And we did have various criticisms of the trial, which, I always like people to have if someone starts to criticize your trial or getting enthusiastic about it, then at least they're paying attention to the results. And this is John Mandrol is very famous for his social media, and I've met him 2 or 3 times. Very nice chap. Although I think he didn't quite read the less aggressive stress testing in the standard care arm, because 85% of people had a stress test in the clinic, and you could have free use of non-invasive stress imaging if you wanted to afterwards. But various people have commented on how certain can we be about the results. It's an open label trial. Preventive variance is not that good. Implausible effect sizes, etc. And also, Sanjay Kaul, who I've not met, but I'm sure was a nice chap, did highlight that there were 22 pre-specified secondary analyses, and if you applied a Boniferoni correction to all of those, you might get your p-value above 0.005. And also the concern that this was an open trial and you could have case ascertainment bias. So I think these are all important points to consider. And I suppose one of the things that I want to flag up, certainly in terms of how should you adjust for multiple secondary endpoints. Of course, when you're doing a trial, if you don't pre-specify them, then it's ad hoc hypothesis generating. If you do pre-specify them, and everyone tells you have to adjust for multiple comparisons, and you shouldn't have too many, and really. But of course, if you change a diagnosis, fundamentally, that is going to change what you do afterwards. One of the best examples of talking about harking, which is hypothesis after results are known, is the ISIS trial, which I show at the top there, which, if you remember, was thrombolysis and aspirin. And they did the reviewers of the paper, because it was such an interesting paper, they were made to do all sorts of secondary analyses, and the Oxford group got a bit fed up with this. So they said in all these secondary analyses, they want at the top of the table, they want to do their own subgroup analysis by birth sign, and showing that if you were Gemini or Libra, you didn't get any benefit from aspirin, whereas if you were another birth signs, you got a huge benefit. Just to highlight that you can overcall all of these things. But Carlos Boniferoni, in his original description of the correction, of course, was talking about doing that sort of analysis where you've got something that is completely far removed from what your primary hypothesis or question was, such as astrological birth signs. But here, our 22 secondary endpoints were, if you change the diagnosis, do you change it so that you really believe it, and you change the investigations, their treatment, and their ultimate outcomes? And of course, they're interdependent on each other. They're not independent. And so any kind of correction is difficult to know how to best correct for it, because if you change the diagnosis, you will change all of these things, because that is what you do in medical practice. So I'm not sure I quite agree with Sanjay Kaul's correction factor there. The other thing that I think is legitimate to think about is open label trial. And we didn't do endpoint adjudication. We did electronic health records, and we followed them patients up through the Scottish national data sets. Now, there's an example here on the right-hand side from the ASCEND trial, which is from the Oxford group, which looked at aspirin, omega-3 fatty acids in a primary prevention trial. And they had rigorous endpoint adjudication, clinical site or investigator reporting. And then they compared the results of that trial with what they would get from the English electronic health record systems. And as you can see in the graphic on the right, there's absolutely no difference whether you do it through electronic health record systems or whether you do it through rigorous endpoint adjudication and oversight. Now, of course, the numbers are slightly different, but the actual hazard ratios and the estimates are virtually identical. And when you come down to it, if you actually look in Cochrane review of what endpoint adjudication actually does, there's no evidence that it actually makes a huge amount of difference. And in the Scott Hart trial, we used routinely collected health records data. Now, these people were not actually the people recruiting into the trial. These weren't even in-site investigators. This was the National Health Service telling us whether the patients had had or had not had a heart attack. So in some senses, to me, that's the gold standard. If you introduce a new treatment into a healthcare system, it's the healthcare system sees more or less myocardial infarctions, then surely that's what you need to know. And actually, if you are interested in these sorts of things, we did write an opinion piece in the Lancet about endpoint adjudication, the costs, the complexity. Okay, it might have specificity, but it's pretty insensitive at times because you end up rejecting an endpoint which may have occurred, but you just don't have the information to know for certain whether it did or did not happen. And so it's not quite as clear cut as that, but I certainly feel for the Scott Heart trial, the case ascertainment bias, someone would have to go in and look back 5 years ago to the previous CT angiogram to see whether that's going to influence whether they did or did not call it a heart attack. And arguably, CT increases the diagnosis of coronary disease, so surely it make you more likely to report a chest pain episode as a heart attack than not call it a heart attack. But I suppose that's a moot point. So are the results fragile? That's the other question that was raised, and this is some of the work that Michelle Williams has done, looking at the CT angiograms and looking at the outcomes. And we've seen that in Scott Heart that you're less likely to enter the cath lab with normal coronary arteries if you've had a CT first. You're more likely to have actionable disease and have obstructive disease on the invasive cath. And of course, the PROMISE trial came out at a similar time. Of course, that was much more of a head-to-head comparison. That was 10,000 patients with atypical chest pain. Scott Heart had the full spectrum of chest pain symptoms, whereas PROMISE was very specifically atypical chest pain, and actually 25% of people didn't actually have chest pain in PROMISE. But they saw exactly the same thing. If you randomize someone to a CT versus a perfusion test, you got much less likely to have normal coronary arteries in the cath lab and much more likely to have obstructive disease. So the CT does seem to be telling us the truth of what's going on in the coronary arteries. And indeed, this is an individual data patient meta-analysis done by Mark Dewey's group in Berlin. We contributed a significant 10% proportion of this data to this analysis, and showing that CT scanning is incredibly sensitive for the identification of obstructive coronary disease. Specificity is slightly less so, of course, calcium blooming and other challenges of assessing whether it's truly obstructive or not. And of course, if you show the same invasive coronary angiogram to two cardiologists, you'll get a different opinion as to whether it's obstructive or not. But these sorts of levels of sensitivity and specificity are pretty hard to beat, and even PET would be struggling to do any better than that, particularly on the sensitivity. If we're to ask the question, is it actually, let's put aside obstructive disease and just look at whether there's any coronary disease, actually, I think CT angiography is the gold standard now. And this is the discharge trial, which was a multi-center European trial, which randomized several thousand patients to CT first or invasive coronary angiogram first. And actually, what you can see highlighted there is that CT detects more atheroma than invasive cath does, because of course it sees the lumen, it sees the wall, not just the lumen. And so if you want to know whether someone's got any evidence of coronary disease, it's not an invasive cath you need, it's a CT coronary angiogram. And I think that is clearly a very important point, particularly on decisions of preventative therapies. What about risk stratification, though? A lot of perfusion studies and protagonists of nuclear perfusion will say, well, it's a very good risk predictor. So we did look at this in the Scott Heart trial. We looked at the humble treadmill test, of course, and categorized them as negative, positive, or equivocal. And what we found was that it did indeed, a positive treadmill test is very powerful in terms of risk prediction, 2 to 3-fold increased risk compared to normal or equivocal. But about a third of the myocardial infarctions that happened in the Scott Heart had an abnormal test, but that means that 2/3 did not. So the 2/3 of MIs did not have a positive treadmill test. Whereas you contrast that with a CT scan, if you had a normal coronary angiogram, there were a couple of events hiding in there, mostly because of poor image quality and you couldn't see all the territories. But putting that aside, you can see that obstructive disease is a very powerful predictor, and non-obstructive disease is also a very powerful predictor. In fact, half of the MIs that happened in Scott Heart, patients had non-obstructive coronary disease on the CT angiogram. So it's really changing the paradigm around a little bit here in terms of risk prediction. PROMIS saw almost identical findings. Of course, in PROMIS, the functional testing was nuclear perfusion predominantly. There were some treadmills, there were some stress echoes, but 70–80% were actually nuclear. But you saw exactly the same pattern. If I flip between the two slides here, you can hardly see a difference in terms of the profile. In PROMIS, they found that over 50% of the MIs had a normal functional test. So really not very sensitive. Whereas when it came to CT, highly sensitive. If you had normal coronary, it's very unlikely to have a myocardial infarction. And if you had an abnormal CT scan, 10 times more likely. And again, the non-obstructive disease was where most of the MIs were happening. So if most of the MIs happen in non-obstructive disease, nuclear perfusion imaging has got no chance of detecting that because by definition, it's non-obstructive. And then finally, we have the ischemia trial. Love it or hate it. It did, when you look at the outcomes, the degree of ischemia did not predict outcomes, whereas the severity of coronary disease on CT predicted outcomes both of all-cause mortality, myocardial infarction, and the primary endpoint trial. Really, again, underlying that CT is a much better risk stratifier than ischemia testing. Going back to the PROMIS trial, people often say to me, well, Scott Hart was positive, PROMIS was neutral. And of course, for its primary endpoint, it was. But if you look at the primary endpoint of PROMIS, you'll see that it had quite a lot of extra things. We had coronary heart disease death and non-fatal MI, whereas PROMIS had all-cause death, myocardial infarction, hospitalization for unstable angina, major complications of procedures and diagnostic testing. And I think the red really hindered any ability to distinguish between the two because there's a lot of noise generated in that. And actually, when you look in the supplement of the PROMIS trial, if you dig it out, you'll see that they did have a pre-specified one-year analysis for death or non-fatal MI, which actually was remarkably similar to the very early reports of Scott Hart when we had a similar length of follow-up around 1 to 2 years. And the hazard ratios, confidence intervals, and p-values are almost identical. So I think these are remarkably consistent. And I think this fragility of the results really is, I think, not the case because we have very robust 2 trials showing very similar things. And PROMIS was different because of the head-to-head comparison, the atypical nature of the patients, but also I think their primary endpoint was a little bit of a hodgepodge of different things. Of course, we also now have the discharge trial, which came out last year, which looked at invasive angiography versus CT. And actually CT came out better, and perhaps partly because it was detecting a lot of subclinical disease or disease that you can't see on invasive cath, perhaps more ready uptake of preventative therapies in that group, I don't know. And actually, when you added in procedural complications, on this occasion, it didn't, because the complications obviously with invasive cath are a bit higher. Actually, that added value to doing a non-invasive test and clearly demonstrating that CT, if you add in the benefit and the complications, you get a much better outcome. So I think we're now in an era, I think, where CT is more widely accepted. Certainly NICE have since 2016, 7 years ago, have been adopting it as the first-line test. The European Society of Cardiology, I'm a little disappointed in their 1B. I think that there are multiple trials now that have shown the benefit of CT. And I was really pleased to see that North America had a much more enlightened approach to recommending CT and tying it very closely to the evidence of the diagnosis, risk stratification, and treatment guiding benefits of CT angiography in line with Scott Hart's findings. It's all well and good to have it in the guidelines, but does anybody listen to them, take any notice to them? This is a survey done a couple of years ago in Europe, and arguably CT angiography is now the first-line test of choice, almost the same level as pre-test probability testing. I think we could talk about pre-test probability. I'm not entirely sure that's the right thing to do, but we can perhaps chat about that in the discussion later. But certainly this is the data from across England. Jonathan Weir McCall dug all this data out, 2 million investigations across England over a 9-year period. And what you can see, the yellow line is when Scott Hart and Promise came out, and you can see the red line there, which is the use of CT angiography really going a bit of an upkick, and NICE in the grey dotted line. Arguably, the upkick had already started, but NICE certainly encouraged it further. And what you can see is that there's a decline in SPECT imaging, slight increase in MR imaging, but actually beyond the guideline, you can see that actually we're starting to see a fall in invasive cath, because I think CT gives you that confidence, and actually it stops normal patients with normal coronary arteries getting into the cath lab. So you see that slight decline occurring. And actually, slightly provocatively, if you look at the pattern of how the imagings have changed over the years, certainly we're seeing that the regions which embrace CT and had the highest increase in CT use and capacity per 100,000 population, they saw the biggest falls in cardiovascular mortality, whereas regions that did not embrace CT and have not increased their access for their populations, they have a lack of decline in cardiovascular mortality. So, of course, there are many reasons for that, potentially. I don't want to overplay it. But it's also interesting, if you looked at MRI, where you saw there was a continuing rise in that, regions that had a rise in MRI, it had no effect on overall mortality, whereas at CT, there was this association. So a bit provocative, but interesting nonetheless. So that was the Tribulations. Where are we heading next? Obviously, we've been using it in a diagnostic context. Where do we see things coming down the road? Well, obviously with CT, it's not just a yes/no dichotomy of yes, you have coronary disease, no, you don't, or yes, you have obstructive, no, you don't. We've got so much more information. Of course, plaque characteristics and characterization are critical. This is the seminal paper from Matayama in Japan, looking at CT plaque characteristics, and the things that we're all well aware of and used to, being high-risk plaques, but they compared acute coronary syndromes patients with those with stable angina pectoris. And you can see that those with acute coronary syndromes had positive remodeling, non-calcified plaque, and spotty calcification, whereas those with stable angina tend to have large areas of calcification, something we can perhaps chat about and come back to a bit later. But these characteristics really do have some extra detail and characteristics of the patients. And certainly when Michelle looked in the Scott Hart population and asked if you qualitatively looked at the angiogram and said, yes, that looks like an adverse plaque characteristic, those that had adverse plaque characteristics had a much higher event rates than those that didn't. And arguably that was as powerful as whether you had obstructive coronary disease or not. Although it does beg the question, are you really going to go through every CT coronary angiogram and tirelessly characterize every plaque that's in the circulation? Perhaps a little bit challenging. But working with Damini Day in Cedars in LA, Michelle and I got to use the AutoPlaque software. Of course, there are many different types of software, not just AutoPlaque, now available on the market, but just being able to characterize volumetrically the type, nature, and volume of the plaque, I think, is quite critical. And this was for me, one of the big papers that Michelle Williams did on the Scott Hart data set, was to ask the question of terms of risk prediction, what's going to be best. Is it going to be a risk score? Is it going to be area stenosis? Is it calcium score, calcium burden, total burden, or the low density plaque burden, the sort of lipid rich plaque that we worry about? And actually, when you look at all these things, they all correlate with each other. So, stenotic disease correlates with positive remodeling, for example. It correlates with lots of different features. And I think that's why stenosis has been such a great risk predictor over the years. It's not necessarily the diameter or the residual lumen that I think is so important. It's how much plaque you've physically got within that. And certainly when Michelle looked at this using quantitative plaque characteristics, and you threw everything into a multivariable model, including stenosis, including risk clinical factors, the thing that persistently dropped out was the low density plaque burden. And as you can see, that gives you a risk ratio of nearly 5. So really driving home, I think, the concept that yes, stenosis is important, perhaps more for symptoms actually, but when it comes to prognosis and your likelihood of having a myocardial infarction, it's how much plaque you have and the type of plaque you have that really is going to predict your outcome. And now with Damini's work, we're almost onto automated systems now, where you can actually, rather than spending an hour, I scan down to half an hour to 20 minutes now, down to 5 minutes. You draw the central line in the computer with these AI techniques, really can analyze these things very rapidly. And I really believe that this is going to be the future for what we're going to be doing. We've applied it to other data sets, not just SCOT-HOT2, but also to rapid CTCA trial. Rapid CTCA was acute chest pain presenting to the emergency department. So these people, about 50% of them had an acute coronary syndrome, 40% MI, 10% unstable. So quite a mixed bag of people. They had to have a troponin elevation or an ECG change or a past history of coronary disease. And when we looked at the plaque characteristics in that population, we saw the same thing. Total plaque burden was incredibly predictive of outcome. Calcified plaque, not so. We can come back to chat that again. But again, the low attenuation, non-calcified plaque really identify the people at risk. And finally, I suppose in terms of CT is the pericoronary fat assessments that we're now seeing from Harris Antonides' group in Oxford, which looks at the perivascular fat, pericoronary fat. And he's done some very nice work with some German and European cohorts looking at this pericoronary fat density to see whether you can predict risk, and some very nice data showing that it really can do. And the concept here of perivascular fat, a marker of inflammation, either inflammation going into the artery causing plaque or the inflammation of the plaque going out into the fat. And we have looked at this, but to try and correlate between the pericoronary fat and the actual intracoronary plaque in the lumen, in the arterial wall. And when we've done this work, we do find that the plaque burden is probably the most dominant, rather than the PCAT, the pericoronary adipose tissue attenuation. I think it is an interesting area. I think a lot more work needs to be done. It does seem to be mostly in the right coronary artery, so it can't just be local inflammation. It certainly doesn't correlate in our hands with systemic inflammation. And I chat to Harris a lot about this, and I think there's still quite a lot we need to understand about what this signal is truly telling us and how independent it is. But he has done a lot of work. We shared the SCOT-HOT data with him. He took the next level of radiomics approach, where you take every single feature that you can see and those that you can't see, to develop an algorithm to test that. And he certainly used the SCOT-HOT data set. We shared that with him. And this is the data that he produced on that, showing that if you incorporate both the radiomics approach and the plaque, you do seem to have a synergistic beneficial effect in terms of risk prediction, which I think, as I say, I think we need to keep a close eye on this developing field. Next, I want to turn to plaque activity, having talked a little bit about plaque burden. One of the areas that I've been interested in is the coronary calcification. Of course, coronary calcification is pathogenomic of coronary artery disease. But we got interested in using a PET technique using sodium fluoride. You're probably more familiar with that in your toothpaste than anywhere else, but sodium fluoride, radioactive sodium fluoride, F18 sodium fluoride, is used as a bone tracer and is a marker of calcification activity. It binds to hydroxyapatite crystals. So we started to do some work on this. Mark Dweck sort of led the initial work on this. And this, I'll always like to show this example. This is a patient, as you can see, who's got right coronary artery with a filling defect in the just near the ostium of the right coronary artery in the proximal section. You see that lovely filling defect. And on the left-hand side is the antecedent CT coronary angiogram. Oh, well, it's not quite an angiogram, but it's a CT scan with sodium fluoride PET imaging. And what you can see is on the right-hand side of that CT image is the heavily calcified left anterior descending coronary artery. And then on the left-hand side, you can see the right coronary artery in that proximal segment, just where that clot is, a very high uptake of sodium fluoride, suggesting that this might be marker of a culprit plaque. Nick Joshi, who did his PhD with Mark and I, he went on to study many patients, over 80 patients with coronary disease, 40 of whom had an acute MI, 40 with stable disease. And you can see that we were able to identify the culprit plaque in the vast majority of these patients. Time and again, we could see the sodium fluoride lighting up in areas of plaque rupture, the culprit territory of the myocardial infarction. And so What the sodium fluoride is doing is it's telling us that this vessel is actively calcifying. And I like to think of it as a concept a bit like TB. When you've got the tuberculous granuloma, which you can't get rid of, the body walls it with calcium to make the GON focus that we can see on the chest X-ray. And I think the same is true with coronary atheroma. You've got a necrotic inflammatory tissue you can't get rid of, so the body's approach is to wall it off with calcium. And I think if it makes a massive wall of calcium, then of course it stabilizes the plaque, and that's why we see large macrocalcification in stable disease and early spotty calcification in unstable disease. And so this is a sodium fluoride is a marker of active calcification of an atheromatous plaque. And indeed, when we looked in the stable patients, we saw the same thing. So this is a CT of a patient who right coronary artery, and you can see that in the proximal right coronary artery, there's an area of calcification and a little bit of atheroma. And on the mid vessel of the same patient, the same artery, you can see in the mid vessel there's some sodium fluoride uptake. And what you can see in the virtual histology IVUS, as it tends to be called, the IVUS images of those two plaques, you can see on the right there's a lot of white and not a lot of red, and on the left a lot of red as well as some white, and the red being a necrotic core type plaque. So really it does seem to be that sodium fluoride is telling you about the more necrotic core that's actively calcifying because it's in danger of rupture. And indeed, we have some evidence from a group in China on the left here who have published some coronary endarterectomy specimens, and those plaques that had high activity of sodium fluoride had a lot of inflammatory cell type, tumor necrosis factor, macrophages, interleukin-1 beta, whereas when there's low activity, this was much lower. Alistair Moss, who worked with me, also did some lovely post-mortem studies, very difficult to do. But again, in those that with sudden cardiac death, we saw evidence of a lot of high activity of the sodium fluoride correlating with active microcalcification within the vessel. So how would we use this technique clinically? Well, together with Piotr Slomka, again at Cedars in LA, we've produced an approach to measure the total coronary microcalcification activity, as we called it. So you can see on the image there, we've got the coronary arteries, we've got 3D volumes of interest, the green that surround the coronary arteries, and then we can assess the uptake of the sodium fluoride. And so you should think of this as being like a calcium score, an Agatston calcium score, but now for plaque activation throughout the coronary tree. And so we went on to look at this. Jacek Kavinsky and Evangelos Zolos that did their PhDs with myself and Mark have looked at this, and they've gone through all the patients that over the years have been done in Edinburgh and in Cedars. So around 300 patients. And we looked at the coronary microcalcification activity in our cohorts and looked at their outcome. And those that went on to have a myocardial infarction had a much higher CMA value. And indeed, when you compared it to other scores that are around to risk stratify them, actually the sodium fluoride CMA was much higher discriminator of problems going forward. We also then had a cohort of patients who had aortic stenosis, and of course many of them have coronary disease. But we wanted to ask the question, is this specific for a certain territory? So we've done this for coronaries, and Alex Fletcher, who worked with us, he looked at not only the coronary uptake, but also the ascending aortic uptake. And he did this and then in about 400 patients, because we had these patients with aortic stenosis and other conditions that had sodium fluoride imaging. And what he did was he showed that, quite intriguingly, that if you had high uptake of the ascending aortic aorta of sodium fluoride, that your risk of stroke was much higher, whereas your risk of myocardial infarction was no different if your aorta had an uptake of sodium fluoride. The corollary of that was if you looked at the coronary circulation, the risk of myocardial infarction was obviously increased quite substantially, but the risk of stroke was not affected. So it does seem to be territorial specific. So the territory where the vasculature is got active microcalcification activity, then it predicts the downstream clinical events. So coronary is myocardial infarction, aorta stroke, but not vice versa. So we then finally thought, well, we better prospectively prove this. So we did a multi-center study incorporating 9 centers, 7 in the UK, 1 in Australia, 1 in North America. Recruited 700 patients with a recent MI who had multi-vessel disease, and we did the coronary microcalcification activity, which we have presented at a conference but yet to publish. But essentially shows that the coronary microcalcification activity does indeed predict the risk of cardiac death or non-fatal MI, or indeed all-cause death. So prospectively validating that this does indeed seem to be something that we should be focusing more in terms of risk prediction. I think I'm running out of time, but I'm going to very quickly perhaps skip over some data that will just show you we've got some early data looking at coronary thrombosis. I won't explain to you in too much detail, but we've got a tracer that not binds to calcification, but it binds to thrombus, to activated platelets. We validated this in vivo system. And these are some early images of patients who've had a myocardial infarction. And you can see that the tracer lights up intracoronary thrombus. Really quite an exciting technique, I think. We've done this in around 50 patients. And what we found is that it can light up the culprit plaque. The example on the left-hand side here, patient with triple vessel disease, but it only lights up the culprit plaque, where the patient subsequently went on to have intervention of the right coronary artery. It's not taken up in the non-culprit vessels. This is a lovely example. I always like to show this one, partly because I had to get out of bed in the middle of the night to treat this patient who came in with an infraposterior MI, and you can see that the circumflex artery is occluded. You can see there's a large filling defect there, which I chose eventually to stent and occlude it against the wall. And they went on to the next day to have a PET CT scan, and you can see on the top panel there that the stent in the circumflex lights up with the tracer because the thrombus obviously is trapped behind the stent. But what we hadn't quite expected was that there was also thrombus lighting up in his left atrial appendage. And in fact, he did have some paroxysmal atrial fibrillation in the post-MI phase, which is not that uncommon. But that now changed our opinion that this was actually probably a coronary embolism, even though he did have some diffuse atheroma, or perhaps was a bit hasty in stenting it maybe. And this was a type 2 MI from a coronary embolus rather than a spontaneous type 1 MI. And so we started him on anticoagulation. We also saw intraventricular thrombus, also intramyocardial hemorrhage, plus or minus microvascular obstruction, depending what you think. So I think that sort of technique might be useful perhaps in Monaco patients. We're not quite sure whether it's thrombotically caused or not, but certainly something that I think that increasingly we're starting to use both in myocardial infarction, but also in stroke of uncertain origin. So I'll stop there. I acknowledge all my co-workers here and abroad, and leave you with a sight of Scotland in the sunshine. Thank you very much.
Thank you very much, Dr. Newby. And what an amazing lecture, and congratulations again for all your work and how you're changing how we treat and how we identify coronary disease. So please put your questions in the Q&A. I'm sure people will have different questions, and we can start. Mario, if you want to start with a question.
Yeah, no, that was a wonderful presentation, and I wanted to maybe share with you some of the things that you mentioned about the comparison of trials that were done, particularly the PROMISE versus your trial. And one of the things that has been very clear from many of this is that there's a significant selection bias when you identify individuals to enroll in many randomized clinical trials, which is a handicap. We saw that in Courage, where probably individuals who had the expectation that we're going to have a good outcome with a procedure were probably not enrolled. And those that have more difficult disease perhaps were the one were enrolled. We saw that with ischemia, where the enrollment really changed depending on the type of institution where the trial was conducted. Large part of enrollment done in Asia and Eastern Europe, and very little in the private hospitals in North America. And one of the conclusions, if you look at the data from PROMISE versus the data from your trial, is that the prevalence of event, the incidence was very low in PROMISE. So this was really a very low risk population, suggesting that the individuals that were more likely to have typical symptoms were more likely to not be included in a clinical trial, but rather being treated clinical. And that's one of the advantages of your approach. I wonder if you have any comments to that effect.
Yeah, I think PROMISE has many strengths, and every trial has its strengths and weaknesses. I think they did pick a typical population, and I think the rationale for that, and some people took me aside after Scott and said, we just couldn't randomize people with typical angina because they're in the cath lab the next day. I mean, it just wouldn't happen. So I think they went for the atypical group because they wanted to try and capture those that wouldn't go straight to the cath lab. The event rate in PROMISE was about 2 to 3 times lower than in Scott-Hart. Of course, the population size was 2 to 3 times larger. So actually, the total number of events wasn't too dissimilar when it comes to the hard endpoints, but nevertheless, it was still quite low. I think in Scott-Hart, if you were in the chest pain clinic for seeing a cardiology team for your symptoms, you were allowed to be included. We kept it as broad as we could. So we had really low risk, so arguably lower risk than we saw in PROMISE, but also even higher risk than we saw in PROMISE. And so there's a big spectrum. And interestingly, the PROMISE risk score that you may have heard of, where they come up with a score to not do an angiogram, actually performed better in the Scott-Hart population than it did in the PROMISE population, which is pretty unique for a score to actually work better in another population, usually it's the other way around. But I think the reason for that is because they had such a narrow population of atypical symptoms. And I think the strength of, CT is purely diagnosing the presence or absence of coronary disease. And I think, and that is so fundamentally important. Whether it's obstructive or not, you can argue about, but actually, yes, you need statins. No, you don't. A bit of aspirin. No, you don't. It's very powerful, and that prevents events. Now, when it comes to symptoms, I think both PROMISE and Scott-Hart didn't see a huge difference in symptoms, whether you had a functional test or whether you had a CT test. So if you're trying to get rid of the symptoms, which of course is what they've come for, I don't think there's a huge difference. But if you're trying to prevent MIs, then I think CT is far superior because it's telling you, whether you've got disease and treating them. And I think that's true in PROMISE as well. And as I showed you, remarkably consistent, actually. And PROMISE, unfortunately, couldn't do the follow-up. We had an electronic health record system which allowed us to do that effortlessly. I think I paid about $1,000 for the whole follow-up data, just because it was available anyway, and I just had to pay someone to collect it and send it us. So I think that is the beauty of our approach, is that we took all comers. We have a very well-developed, audited healthcare system that actually checks on the diagnosis, and actually, as I said in my talk, I think it because it's independent of the trial team in many ways, it's more robust. So yeah, I think PROMISE told us a lot. I think Scott-Hart told us a lot, and I think the two together, I think, are very powerful.
Yeah, I make one more comment. I think ischemia also told us a lot, and the big surprise in ischemia is what's a high number of patients with severe ischemia who had normal coronaries when they went to CT. That it certainly goes along with how the prevalence is so high of normal coronaries in those places that have not endorsed CT when they're doing diagnostic cath.
Thank you very much for the answer. And we have a question from Daniel Lorenzati. He asks if you can comment, as you mentioned briefly before, on the type of symptoms and then on the pretest probability, and if you could comment briefly on the Scott-Hart too.
Yeah, so the symptoms in Scott-Hart 1, there were about, from memory, and it's getting a bit vague now, but it was about a third had typical angina, 40% atypical, and the remainder were no, actually it was 25%, 35%, and 45% of typical, atypical, and non-anginal chest pain. And I think, and what often happens in chest pain clinics is that the primary care physician knows it's not angina, but the patient smokes, is diabetic and hypertensive, and doesn't want to make a mistake. So they send them to someone else to say, this isn't angina, right? And so you had a lot of people with risk factors who didn't really have angina, and actually the CT gave her the confidence to then say, no, you definitely don't have angina. Pre-test probability, I don't like. I really don't. I can see the arguments for trying to rationalize some things and stop people doing silly things, but the patient comes to the clinic and says, I've got symptoms and I want you to tell me whether it's angina or not. And if I say, well, you got a less than 5% chance of having angina, they'll go, well, yeah, so it's still possible. Have I got angina? Haven't I? Have I got coronary disease or not? So and NICE, of course, has thrown out pre-test probability. So, and they said you do it on the grounds of possible angina. And they define that as either typical or atypical, or non-anginal chest pain with an abnormal ECG. And that's a pragmatic approach. I think that's just as good for me. And patients do often want to know. And I have, I'm easily persuaded by the patients when they're very anxious about it to just do the CT and be done with it. And often you will find out things you weren't expecting. And I suppose that is the rationale for Scott Hart 2, which is when we looked at Scott Hart 1, we saw that if you looked at the hazard ratio reduction of events, the biggest one was in those with non-anginal chest pain. And that harkens back to this, probably just multiple cardiovascular risk factors, people being referred up. So we're now doing a 6,000 patient study. We've recruited 3,000 so far, and we're getting them from primary care. So we're taking people between the ages of 40 and 70 with one risk factor. And then they get randomized to the assigned score, the Framingham risk equivalent, or a CT scan. And it's going to be interesting to see whether that shows exactly the same, because it is the prevention of events that CT is very good for. And there's also the issue certainly in the UK, I don't know what it's like in the US, but patients often don't want to take statins. They often feel a little bit cautious about it. So what we're finding with the Scott Hart 2 so far is that people who have the risk score are less likely to take their statins. Whereas if you do a CT, about 50 or 60% will have some coronary disease. And they're much more likely to take the statins now because they've got disease, they've got early disease, that they've got no symptoms and they don't want to get any. So they're bought into actually the preventative therapy and the lifestyle changes. So it's going to be interesting to see how that pans out. But we hope to finish off recruitment in the next 18 months. And then obviously we'll be reporting that probably about 5 years from now.
Thank you. We'll have to wait a little bit.
Yeah.
So what are your comments on the 4%? There has been some criticism about that number, the 4%. Should we focus on the 4% for low attenuation plaque as a risk estimator, or how will we deal with that?
Yeah, I mean, I think so the low attenuation plaque in terms of its volume is quite small, and it really is tiny, and you could argue it's very variable. It's at the borderline of sensitivity, and the same is true with the pericoronary fat. You're talking about 3 or 4 Hounsfield units difference. I mean, that's a small amount really in absolute terms and on an individual basis. But I think as scanner technologies get better, and as we get better at characterizing the plaque, I think this is going to be something that is going to come to the fore. I think for me, it's mostly about non-calcified plaque that I'm most interested in. The lipid-rich plaque seems to be the ultra-most, but we've still got to learn a little bit more about that. And I think, it makes rational sense. Whether it's true or, actually plays out this way or not, I don't know. But the more disease you have, the more trouble you're in. We know that. And the more unpleasant the plaque looks, the more softer plaque you've got, the more likely it's associated with events, the more intensive we should be with our therapies. Aspirin, statin, then perhaps a PCSK9, then perhaps other treatments that might come along. So I think it's certainly, I think people are much more interested now, I think, in terms of the quality and quantity of plaque rather than the luminal stenosis. Not that that's not important, symptoms in particular, but for events, it's all about the plaque.
Thank you very much. I think the difficulty for the people receiving the report sometimes is how to act based on these reports. It's so important that you guys encourage the preventative therapies. We have a question from Scott Monrad on sodium fluoride. So this is just as research now. Where do you see the progress into a clinical application, and in which patients you think it could be used first?
Yeah, I mean, it is difficult because I think, certainly predicting events in people who've had events, so, post-MI patients, is really difficult to predict. The GRACE score and all these sorts of things, they have some value. But even when we throw the GRACE score level of obstructive disease, the sodium fluoride still adds additive value in terms of risk prediction. Is it something we'd want to do in everyone? Probably not. No, I think it's sophisticated technique. You can actually just, if you've already done a CT coronary angiogram, you can just get the sodium fluoride PET and co-register it. And sodium fluoride is the cheapest PET tracer you can possibly imagine, because it's just the salt which is often used to make FTG. So it's widely available and easy to get hold of. But you've really got to want to know in a certain patient whether your risk stratification, you're not quite sure. And if it's not going to change your management, why would you do it? You're just going to worry yourself a bit more, worry the patient more. Some of the thoughts that we've had have been around intensification of therapies. When to press the trigger on the PCSK9 on top of the 80 of atorvastatin or the 20 of rosuvastatin. Is that the time? We've also thought about pre-op risk assessments in patients with complex coronary disease, because of course a stress test, as we've seen, it will it'll tell you whether they're hemodynamically running into trouble during an operation, but it doesn't necessarily mean whether plaque rupture event's going to happen during a procedure. And so if the CMA was negative, then you would be much more reassured. If it was positive, what would you do? Well, it depends how important that operation is, I suppose. And then we've also thought a little bit about whether it'd be better at identifying culprit plaques, and some of the interesting things that we've seen where people are treated what's the most stenotic plaque, but actually the sodium fluoride is not often the stenotic plaque. And so not to intervene is something that will be challenging to do that, but it might help in some senses of selection of which is the most problematic plaque. But I would come back to a slightly earlier point that you made, which is what we're going to do about it. If you've got a high risk plaque, you're going to stent it. Well, no, we don't know whether that makes any difference, and I suspect it won't. And actually, the positive predictive value of a high risk plaque is really low. So it usually sits around 10%. So 9 out of 10 plaques do not cause an event that are hot and look horrible. And we know that silent plaque rupture happens all the time and actually resolves without a clinical consequence. So yeah, I think it's going to be an important question. I think there are some other areas of cardiovascular sodium fluoride which might be more relevant. We've got some nice data on aortic aneurysms, for example, which might influence what you do. But for coronaries, I think it clearly is a risk predictor. It proves the point that plaque activity predicts events independent of volume, independent of stenosis. But how we'll use that clinically, these are just some of my vague rambling thoughts at the moment, but there's not a clear major problem it's going to solve for us.
Thank you very much. And I think one last question, do we have enough data to say that the plaque characteristics predict events above calcium score?
So that's a good question. They are interrelated, of course. The more calcium you have, the more plaque you tend to have, so they are collinear. In some of our analyses, calcium score came up on top, but as we move to more progressive quantitative plaques, I think we're finding that the plaque is more predictive. And I think there was a nice paper from a Danish group that looked at using calcium score as a marker of plaque burden, and where it performed worse was at the very low and at the very high levels. So when you've got and particularly younger patients, the ones we tend to worry about, and Scott Hart, and in Scott Hart 2, we've got lots of young people that got a 0 calcium score, but some pretty nasty looking plaques. And that's the problem, I think, for calcium is you miss the younger patients who've not had time to calcify their coronaries. Then at the other end, you've got people who've got really a lot of calcification, who've got burnt out end stage disease, and that often, it's difficult to predict what's going to happen with those patients more. So as a simple test, coronary calcium, brilliant. Is it the best test? I think coronary angiography and plaque characterization is better. How much better? Is it worth the pain? I don't know. I think it depends on how you're using it. And of course, if you want to know about flow limitation, if you want to know about stenosis, you're not going to get that from a calcium score.
Well, thank you very much. That was an amazing lecture, and we'll be waiting for the results from the SCOT Heart 2 and the rest of your papers that you'll have in the meanwhile, I'm sure.
Thank you very much, and thanks for everyone for listening and the great questions, and also for the honor of me being able to give the grand rounds today. Thank you.
Thank you. Bye-bye.